Great. Well, I think we can go ahead and get started. So good morning, good afternoon, good evening from wherever you're joining us from. Welcome on behalf of the Boost team to our 7th Bright Spots webinar on routine vaccination through pragmatic financial management. Our colleagues at the Solina Centre for International Development and Research will be leading today's session, but I want to go over a few housekeeping slides first. Next slide. Oh, there you go. So we're using a Zoom meeting format today. So we ask again that you remain muted to minimize any background noise. You can always raise your hand during the Q&A session of this presentation to speak, or as I mentioned before, feel free to use the chat box to introduce yourself, submit questions, and respond to other participants. So again, if you haven't already done so, please feel free to introduce yourself in the chat box. Just state your name and where you're joining us from. Next slide. So for those who are joining us for the first time, the Boost community is a diverse network of more than 1,400 immunization professionals from over 125 countries. Through our online platform, boostcommunity.org, we offer opportunities for our community to connect with peers, strengthen leadership and advocacy skills, and grow in their careers. Next slide. So through our Bright Spots initiative, we recognize that there is innovation occurring at all levels of the immunization system. These bright spots shine a light on the work that is happening on the ground and inspire immunization professionals everywhere to learn, adapt, and take action in their own communities. So this story today is from our first round of what has become an exciting annual storytelling competition. So stories from the second round will actually be released next month. So be sure to bookmark our Bright Spots microsite, which is listed on this page, brightspots.boostcommunity.org, where you can read the stories and then also find out when we have another call for submissions, which will hopefully be happening in the next couple of months. So this collection of stories includes 10 submissions from 6 countries, including Ethiopia, Nigeria, Tanzania, India, Pakistan, and Cameroon. So with that, I'm going to hand it over to Adi from the CIDR team, who's going to take the lead for the presentation today. Over to you.
All right, thank you very much, Liz. Hello, everyone, and welcome once again to today's webinar on routine vaccination through pragmatic financial management. During the session today, we'll be sharing our experiences from implementing the financial management interventions for immunization in parts of Nigeria. My name is Idongesit Samson, and I lead CIDR's routine immunization work in one of the focus states in northern Nigeria. With me today, I have Yusufari from BMJF, who was part of the team that pioneered the intervention, the implementation of the MOUs in Nigeria. I also have Raihana Ibrahim, who anchors the implementation and documentation management aspects of CIDR's immunization work on northern Nigerian states. The objectives of today's session are to share some of our experiences from working with the state governments and donors to design and implement the financial management intervention across 6 northern Nigerian states, and also to highlight some of the lessons that we have learned so far, as well as some success factors from implementation. We'll have ample time for questions at the end of the session, so please feel free to introduce yourself in the chat box, drop your comments and questions as we go along. And at this point, I will hand over the session now to Yusuf, who will lay the background for the intervention and how it came about. Yusuf?
I think you might be on mute, Yusuf. Sorry.
Hello, can you hear me?
Yes, we can hear you now.
Okay, so thank you everyone for joining, but let me use this opportunity to acknowledge one of my very close colleague, a former colleague who took time to at least attend this, Jenny Sequeira from Washington in the US. Welcome, Jenny. Jenny was part of the team that co-created this model, and we are really happy that she's also able to join. And every other person that has joined across the globe, we are happy that you are able to join. So as you will see, The MOUs are essentially a partnership between Aliko Dangote Foundation, which is a family foundation here in Nigeria, the Bill and Melinda Gates Foundation, government of Nigeria, and other partners. It's an innovative engagement model that is being implemented in 6 states in northern Nigeria. And the choice of these states historically has been because of their high risk polio status, and then which was also characterized by significant poor RI coverage and frequent outbreaks of vaccine preventable diseases. So based on this, we evolved this model, and we had other partners that have also joined. In 2023, when these MOUs were developed, these states had very, very low immunization coverage, as you will see in the map which Rehana was showing. And coincidentally, these 5 states accounted for about 5% of global burden of unimmunized children, and indeed very poor other indices across the health system. And budget allocation was exceptionally very low, much below the commitments states have made, which is popularly called the Abuja commitments. Even though these states have high population density and high incidence of vaccine preventable diseases. So our partnership evolved over time from polio eradication to strengthening routine immunization, and now strengthening PHC system. In the next slide, so our partnership actually, to implement the partnership, we commissioned a diagnostics of the IRI system to understand the major drivers of poor coverage and system underperformance. So these diagnostics actually revealed several bottlenecks. Key among these is grossly inadequate funding for recurrent RI routine immunization activities. Most of the funding available at that time were actually for polio activities and other ad hoc activities like the supplemental immunization for outbreak response. And accountabilities were very weak due to the ad hoc nature of the way the program was run and also the way the fundings are available. The immunization system is generally weak, from financing to weak supply chain, inadequate and poor quality data for decision making, absence of mechanism for building capacity to improve the quality of staff, and also improve the quality of the program performance. And demand was exceptionally very low. So to address the funding issue, which is the main subject of this conversation and a subset of the broader MOU, our foundations, that is Aliko Dangote Foundation and Bill and Melinda Gates Foundation, together with other partners like USAID, FCDO, UNICEF, and Global Fund, signed an MOU with the governments of the respective states, with the Federal Ministry of Health and the National Primary Health Care as key participants and overseers of the implementation. And so what we did was to establish a multi-year MOUs that ensures pooling of resources into a dedicated account that is managed by government. But do also note that our partners, because of their internal policies, would not be able to put money directly into the basket, but they were able to put resources through an implementing partner. And under the leadership of government, we were able to, under the leadership of the state primary health care agencies and the Ministry of Health, the teams work to develop, prioritize, and costed routine immunization work plans that address the bottlenecks that were identified in the diagnostics that was done. And this is essentially, the costed work plans were essentially to respond to these issues that were found and also address the program performance. The costing of that work plan is shared across the partners, with government contributing lower percentage in the early years and then increasing their contributions over the period of implementation. But one lesson we learned early enough is that ring-fencing funding for recurrent RI activities in government budget and using other levers, including our voices, to get government pay their contributions are the major drivers of change in the early days. Of course, there were huge risks in this endeavor because of the huge amount of resources that is channeled into a very weak system. But key concerns were essentially around the absorptive capacity of the system and also financial and programmatic accountabilities. And there were a lot of lessons that were learned, and I'm sure the team will present that, knowing fully that this conversation is essentially around the financial component and so may not go into the other broader routine immunization system details. Thank you all, and on this note, I will hand over to Raihana.
Thanks very much, Yusuf. Before we go on to describe the intervention in detail, we'd like to hear your experiences on the highlighted bottlenecks on immunization or any other PhD program that you are implementing, and also highlighting any experiences with donor fund management that you've encountered. What has been the greatest pitfall with donor funding for programs that we've witnessed, and what are the biggest bottlenecks with raising funds for programs in your experience? Please use the chat box to participate in sharing your responses, and we'll allow that for a few seconds to minutes. Okay, I think you can continue to contribute. Looks like we haven't gotten any responses yet so far. There might be a lag in the networks, but looking forward to reading through all of your experiences as well. I'd like to point out that the challenges that we faced in the MOU states at the point of startup was no different from most of the other challenges that we see in immunization programming in similar settings. The MOU approach was understanding that we needed to do things differently and that a lot of innovation would be required to get the system strengthening drive socialized with everyone in the state and get significant results. As Yusuf mentioned, a lot of donors have the interest and motivation to resource interventions through the government, but there are a lot of issues with trust and accountability that often affects their ability or the extent to which they do that. In these 6 states, for the first time, donor agencies put their money directly into government accounts to manage. And this was done through the basket fund. Essentially, the basket fund is a joint account where governments and foundations annually contribute a predetermined amount based on a sharing formula, which is a proportion of X. X in this case is the annual amount that is required to run the program. And it was derived from that elaborate costing after the diagnostics that Yusuf described and worked into the state work plans. I'd like to point here that there are we consider expenses to be across 2 broad components: the capital expenditure, where we have things with procurement, such as procuring solar fridges and doing repairs for facilities, while the operational expenses are things around paying for outreaches, vaccine logistics, equipment maintenance, etc. The basket fund was designed so that in the earlier years, where government was paying a lower proportion, all of the capex was also front-loaded. So because capital expenditure is a lot more expensive or cost-heavy, those were front-loaded so that when the government eventually started taking full responsibility, they were going to be paying or be required to pay lesser amounts. A key lever that was also put in place to ensure compliance was contingent payments. So BMGF would typically put in their money first in good faith and to also spur the state. And then the state will be required to pay 100% of all of their expected contributions for that year before Aliko Dangote Foundation makes the fund drop. And that helped to ensure that all of the government funds are dropped as due. Now, with all of these funds that have now been made available through this pooled system, it was necessary to institute measures to ensure that they were well utilized. And so we described the financial management intervention that has 4 key innovations. The first was establishing the finance working groups to ensure proper governance. The finance working group is comprised of both the government and partners, government taking the lead while the partners were providing TA. Second thing was to establish key financial management processes, and I will describe this further as we go along. Thirdly, we had to build capacity of the state actors. So we embedded professional finance analysts to build capacity of the state actors through the working groups that they participate in. And the approach was really more on the job sessions that required doing together and then allowing them get to the point that they can do it independently, and also rolling out SOPs and tools to get them to do the basic financial management functions, such as budget performance and auditing. It was also important to establish platforms for accountability and oversight. So we had biannual reviews with principals from the donor agencies and the governors discussing the state of the agreement, and that would include the finances, as well as state task force meetings that were chaired by the deputy governors. At each of these meetings, financing and management of funds were a standing item, so everyone was held accountable by a person of higher authority. Now, I'd like to discuss the financial management processes in a bit more detail, understanding that this is the core of the conversation today. The first component there is budgeting, which, like Yusuf said, was very important, that after the resources were raised, we made sure that it was included in the budgets of the states. So for all of these 6 states, when you look into the budgets, you can see the annual RI program costs clearly outlined there as a line item. And a key principle as well for the MOU is having one plan and one tracking mechanism. So the work plan is harmonized and only activities captured in that plan, which is fully costed and includes all of the partner activities, are allowed to be conducted. The second piece of the processes is direct disbursement. To make this happen, we facilitated opening of dedicated accounts at facility and LGA levels. All of these accounts have 2 signatories at least. And then we have the finance team develop disbursement schedules that are informed by the micro plans to directly transfer monies to facilities and LGAs. And because this is a joint account, as we said, the government has to always request bulk no objection approvals for activities on a quarterly basis. And these no objection approvals need to be accompanied by working group minutes and a copy of the work plan so that compliance is ensured at all points. And thirdly, after these monies are expended, end users are required to retire the funds using the easy-to-use tools that we've deployed that helps us to validate that that activity was conducted. So for example, when we're talking about outreaches at the facility level, the health worker is expected to get the details of that outreach, as well as the name and phone numbers of a caregiver and a community leader. So the finance team then conducts validation of that retirement. And we do not just stop there. Where this retirements turn out to be invalid or are not submitted, the finance team has a way of prompting the prompting the actors at the lower levels to refund the money so that all funds are recouped and accounted for. All of these measures, including the audits, ensured that the basket was tightly woven and that every penny had to be fully accounted for. And as such, transparency and accountability became a norm from all of the key actors in the state. Now that we have discussed the what of the intervention, the people that perform these functions are also important. And as we said, the principles of the MOUs are around state ownership and sustainability, and as such, the government is always in the driver's seat. At the state level, we have the executive director or secretaries of the primary healthcare boards who provide oversight on program implementation, approve vouchers and fund requests, and are also a co-signatory to the basket account along with the director of finance. And then we have the finance team that typically comprises a director of finance, a cashier, an accountant, and an auditor that conduct the day-to-day processes. We have the finance working group that comprises all of these people, key immunization program managers, as well as partners. Partners sit at the finance working group to provide TA, while also providing some form of stewardship to ensure that compliance is in place at all points. Similarly, it's worthy of note that at the LGA level, we also have the LIO, that's the LGA Immunization Officer, and the PhD Director who serve the functions that we have for the ES and the immunization managers at the top. And there are also account clerks at the LGA levels that were trained and deployed to ensure compliance at the lower level. I'm certain that after describing this very robust framework, that a lot of people are teeming with questions. So please feel free to start to include your questions and comments in the chat while I hand over to ID to take us through the results from the intervention.
Thank you very much, Raihana, and hello again, everyone. So the MOUs and the financial management intervention has definitely yielded commendable results. First of all, the biggest accomplishment is the availability of funds for running immunization program activities at the state level. Basic activities and basic program activities are fully paid for and costed in the work plan, including financial processes that Raihana mentioned. Through the intervention, we have also successfully opened accounts for over 5,000 health facilities, and this has made direct funds disbursement to facilities possible. It's also worthy to note that these accounts are now being considered for other health facility level funding streams. One example that we have is the Basic Healthcare Provision Fund. More importantly, we do not just have funds available, but the funds are actually now coming from the government. And there are 2 of the 6 states now who have fully transitioned to paying for their RI sums independently. Thirdly, we also have improved transparency. And currently we have over 90% of unspent funds that have been duly recovered across the 6 states through the measures that have been implemented. It's also interesting to note that the 6 MOU states have commenced the process to expand the focus of the MOU and the financial management system to broader PHC. And we also have other partners like UNICEF and Global Affairs Canada joining to put their funds for PHC strengthening through similar systems. There are other countries like Chad and Guinea who have shown interest in the innovation and are currently implementing similar funding arrangements backed by these financial management interventions. And having money in program activities has also yielded improvements in results, such as an increase in the number of health facilities offering immunization services across the states between 2014 and now. We've also seen significant improvements in the availability of functional cold chain equipment across states. Thus, vaccine potency, storage, and availability is guaranteed, evidenced by the stock performance improvements that we've laid out on slide 17. In terms of coverage, we've also seen varying levels of improvements across the states. Although we've not obtained optimum coverage across the states, we believe that continued efforts from state governments and partners in sustaining these innovations will definitely go a long way in further strengthening the immunization system and sustaining the gains that we've recorded thus far. I'll hand over back now to Raihana to take us through some of the lessons that we've learned and some of the challenges that we experienced.
Thanks a lot, Heidi. I'm seeing in the chat that a lot of the issues that people are raising are around sustainability and the complexity of finance. And Jenny is also raising a key problem, which is people not considering financial management a core piece of the program. And we have found that that's something that prioritizing financial management is always the first step to improving program outcomes, because we need funds to actually make the system work. So none of the successes that we've highlighted happened without implementation challenges as expected. And we're able to circumvent most of this by continually iterating. So this strategy didn't all come together in the first day. We've had to innovate along the way by co-creating and brainstorming with the states, and also facilitating cross-learning between the different states so that they're able to share experience. But amongst the barriers that we faced is the major one is really the delay that we've seen in the release of states' counterpart funds for immunization. As I said, part of what was worked into the basket arrangement is the contingent payment. But we've also seen that, and I think that for the contingent payment, if one were to replicate this, even if we had only one donor, what would work or what could work is having payments in tranches such that you can pay some of it upfront to allow program activities to happen, and then spur the state to make full contributions before paying the balance. A major lever that has also helped is the high-level advocacy to the government. So it's having the key officers from the donor agencies, having relationships with the governors, and advocating to them to release these funds on time. There's also the challenge of inertia towards making the change. For something like retirement and recoup of funds, it was challenging to get everyone to be socialized and to adopt to this new way of doing things. How we've been able to make it happen is getting the high-level buy-in from the leadership, and also using those higher level platforms that I mentioned earlier, the biannual meetings with Bill and Aliko, and the state task force meetings that are chaired by the deputy governor. But also providing targeted TA to the states through the finance working group, such that all activities are institutionalized and built on the existing state system. There's also the challenge of inadequate capacity of the line managers to coordinate the implementation of the innovations. So a lot of our work has also been focused on building capacity on the job, getting the officers to also have the tools that they require, the simple SOPs, simple Excel tools, and teaching them the basics of, accounting, or refreshing their knowledge and how to apply it appropriately. There's also the challenge of inadequate oversight at the lower levels. And as I said, there are LG account clerks, but we also have the finance team conduct spot checks routinely to monitor implementation at that level. Throughout the process, as I said earlier, co-creating was very important, and cross-learning was also a key innovation that we've put in place and guaranteed that states do not feel like they're alone in the battle, and that they have 5 other states to compare with. In terms of the lessons that we've learned and the success factors, we can say that the influence and convening power of the foundation principles was very important. We cannot say this story without highlighting that. And so for people who seek to do something similar, we need to think through how to get the governors on the table, how to get the core decision makers participating actively, and also having them review the information or review the program routinely. Continuous advocacy has also been pivotal to ensuring that the program remains non-partisan. Even with transitions in governments, we've changed, the states have had different changes in governments over the 5 to 6 years of implementation. We've also seen changes in commissioners and ESCs of the boards, but continuing to advocate and get everyone on the table has really helped. Building on what exists, creating what is simple and easy to use is also a key success factor. The need to innovate along the way, ensuring that stakeholders also participate in that innovation. And also, as I said again, the dedicated capacity that we put there through finance analysts that not only provide TA, but build capacity is very, very essential. As we get to the end of this session, we'll like to get your questions and any comments. For people who would like to replicate this, a key takeaway for you would be getting the costs right from the outset, guided by diagnostics. So knowing what the problem is from the beginning and developing budgets that will address those. Designing what will work, that is contextualized, and being able or being open to iterating and changing as you go, but also understanding that this is not going to be easy change management. And so being dogged and continually, toughing it through the implementation process is very important. And we cannot do this from a distance. You need representatives at the lower level or at the implementation level with context that will ensure that compliance happens at all times. So thank you very much, everyone. This is the end of the presentation.
Rehana, this is Rehana.
Yes, please, Yusuf.
There were some questions in the chat box, so I want to respond to two as part of the key things to consider when replicating the points you raised. So some of the questions are around inflexibility of donor funding and then cost unit. So I would like to mention here that these cost units are decided by government, under whose leadership the prioritized costed work plans are developed. So they are not the typical partner cost units that you see. And that's essentially to help make it a bit more affordable. And bearing in mind that what is being funded is the recurring cost of implementing the program. There was also a question around sustainability, which there's so many questions around sustainability. Now, what we have tried to do in the last 8 years is to see that the costed programs, the prioritized activities are costed in such a way that it's affordable. And what we have seen over time is that government has successfully increased their funding while the donor funding has been reducing over time. So like in the last 3 years, all the states have been fully funded. 2 states have taken over the funding of their program, while the other 4 have been funding of the total cost of the RI program. And so that's one of the drives and process to make it really sustainable. But of course, there are risks as time goes on because of issue of when there is new leadership change, like Rehana mentioned, whether this leadership would also prioritize immunization and PHC, or whether the new leadership will come with a different mindset. So that mindset and the prioritization approach of new leadership is a huge risk, and we've seen that playing out. But one good point to mention is that so far in the last 11 years, all states have continuously dropped their counterpart contribution. Over from my side.
Thanks for the head start on the comments and questions, Yusuf. I'll hand over back now to Liz to facilitate the question and answer session.
Great, thanks so much, Rana. And we have been receiving a few more comments in the chat. I know some that were just addressed. I think there was a comment from Daniel. He observed that routine immunization providers are going for outreach services just for the sake of the fund. And they will, even if it's only a child vaccinated. So his question is around why routine immunization providers conducting fixed post services not supported with funds because some of them have a very high floor of clients. He mentioned even over 100 a day, yet they're not supported because they're not conducting outreach sessions. Not sure if you want to comment on that.
Thanks, Liz, and thanks, Daniel, for the question. I'd like to point out that the support or the funds that goes to the facilities for outreaches is not a stipend for doing the work. It's transportation costs to get to the outreach sites and return. Also noting that these health workers are all paid salaries, and the salaries are also controlled by the Primary Healthcare Board. So part of the initial work was making sure that all of the PHC staff across all of the states were transferred to as staff under the Primary Healthcare Board, so that administrative and financial control is streamlined in that manner. So health workers get paid salaries for doing their jobs, and the assumption for the fixed session is that you are at the facility and you will provide the services there, whereas for an outreach, you would require a transport cost to get you to the outreach site and back. I hope that that clarifies the question for you. Yusuf, do you want to add to that comment?
Sorry, I missed the last point you made.
Yeah, I was wondering if you wanted to add to that answer around why health workers are not funded to conduct fixed sessions. Yeah. And I mentioned that salaries are paid, yes.
Yeah, so one, salaries are paid, and we are packaging this not as a vertical program, but as a program that is run and managed by the government. So by the time you begin to introduce incentives around fixed sessions, people will start bringing other questions around incentive for even coming to work. And that's not the message we want to send. So this is managed by government. They've already been paying their salaries. And therefore that should suffice. But there are also other things that government is doing within the system to ensure some of the motivation. I saw someone mention around motivation for service providers. Some of the motivation is around the capacity building that they benefit from, the redesign of service delivery model in such a way that it responds to some of their expectation rather than what obtains previously, where things will just be designed for them and pushed down their throat. So there are a lot of capacity building, a lot of mentoring system put in place to enable healthcare workers be motivated to do the work. On funding, it was a deliberate policy that there would be no monetary incentives for that, because it will be unsustainable at the end of the day.
Thanks, Yusuf. Liz, do we have any more questions?
I think we addressed all the other ones that have been asked so far, but I just sent a reminder if anyone wants to share questions via the chat, or if you wanted to raise your hand to voice over your question, feel free to do that. It looks like we have a question from Emmanuel. If you wanted to go ahead and unmute, Emmanuel.
Hi, good afternoon, everyone. My name is Emmanuel Musa, an independent consultant. Very good presentation by the team, and Rihanna, Yusuf, and others. You've done a lot of good work and justice by trying to showcase. With the common basket, which has actually been how it has increased the immunization coverage of almost of the 6 states that you're actually seeing. But I still have a lot of 1 or 2 things and areas that we can be able to look at, most especially in the areas of funding to health workers in the health facility level. Now, it has actually been an issue because I've been in one of those few states, and I've actually seen what has been happening in few of those health facilities, and a lot has been complaining that funds, when actually being uploaded, some actually don't have to, you have a health worker who has been he goes for outreach sessions once, twice, 1 month, 2 months, 3 months, and he is not actually, he feels discouraged because when the funds are being uploaded and then he has not seen his phone for almost 1 or 2 or 3 or 4 or 5 months. Some have even complained for more than that. an effort had been trying to reach the LIOs and then probably the zonal level and even the PSC the board to see if those areas can be rectified have not actually yielded any result. So what is this Solina group trying to do? Because to make these things more better and more accountable, and you know, definitely I know that these things cannot be changed within one day, but then so many things can be done, because while you're on supervision, you should be able to go through. The supervision should not be done probably at the state level, go through to the health facility level and see what is actually happening. And then so that it should be able to give you a clue of what is happening in those rural area health facilities. Thank you very much.
Thanks a lot for those comments, Emmanuel. Wanted to point, I got the latter part of your question, which is really around how we ensure compliance at the lower levels, or how we ensure that the funds actually get down there. So right from the disbursement stage, we collate all of the account numbers of, or the state collates all of the account numbers of the health workers and the LGAs and validate that with the banks. And then every quarter when funds are about to be disbursed, they're disbursed into those accounts. And then we make sample phone calls to the facilities to be sure that the funds are actually received. Now, the financial management monitoring is also worked into other state-led and LGA-led supervision that is done. So RISS is done in such a way that the supervisors are trained when they go to the facility to also inquire about fund receipt, about account management and all of that. And when the validation is also done of the retirements from these health facilities, the finance team takes time to make phone calls and validate the bulk of the retirements that come. And for retirements that they couldn't reach or validate, or retirements that come up with some queries, they conduct financial spot checks to those facilities as even an additional layer on the routine immunization support supervision that is in place. The health workers also have channels of flagging issues, either through the LGA review meetings, where they flag the issues to the LGA team. The LGA account clerk flags that upwards to the state, or through other meetings or other supervisory visits that they receive in their respective facilities. And I hope that that answers your question, Emmanuel. If it doesn't, available to continue to have the conversation in the chat. There's a question from Jenny on where do we see things going in the future if some of these states have other loans or source of funding that is not from the state annual budgets. Thanks, Jenny, for this question. I think we try to highlight that in some of the successes that we've recorded here. We have seen a higher appetite for other donors or other partners to key into this financial management system. And right now, the conversation in the States is really beyond expanding the MOU to broader maternal and child health, to also figure out how we can make it, institutionalize it for all of the funds that come into the state, either through loans, as long as they're coming into health, starting with primary health care, to manage the funds through these same means. These are the same facilities that will receive funds, some of which are even from or for the same activities. So it's right from the disbursement or from the finance working group coordination level, ensuring that all of the stakeholders are sat there, and then making sure that we're using the same accounts to disburse to the facilities, expanding the retirement tools to allow them to, include activities that are not necessarily from the basket, and also to validate accordingly. Knowing that because of the nature of some of these funds, they have extra requirements or extra regulations that guide their use. The states work with all stakeholders to figure out what the middle ground will be and how this would work successfully. Bauchi, for instance, has used the accounts for the BHCPF disbursement that has been done. Some other states have also been able to expand audit to include all of the activities, including the UNICEF account and other donor accounts. So we're looking, the states have commenced the journeys to integrating, and everyone is starting to see how important it is to manage the finances this closely. Other donors like Global Affairs Canada joining the MOUs are also looking to have that level of scrutiny for their funds, even if they don't go through the conventional basket. Over.
Great, so I think there's a few more comments coming in through the chat. And we also have another raised hand. I don't know if Kalilu, if you want to speak.
Hello, thank you, Rehana, for that very good presentation. Mine is just, I'm wondering, given the elaborate outlay for this PHMOU and the different layers and costs involved, has there been any attempt to do some kind of cost effectiveness or cost benefit analysis? Because the elaborate mechanism for delivering the MOU also has come at a cost, at a financial cost. Mine is, I don't know whether you're best placed to do this or Yusuf, but I was just wondering, has there been any attempt to do some kind of cost benefit or cost effectiveness analysis? In addition to just stimulating investment, it will also be good to know that there is real value for money, while we're improving investment and fund release. Are we also spending the money in the best interest of reaching everybody at the least cost? Thank you.
Thanks, Khalil. And I will hand over to Yusuf to answer this more specifically, but I can speak to two things. First, in terms of just looking at the outcomes that we've been able to get in terms of strengthened systems and how well these systems have now become routine and are now expanding beyond immunization. I think that is evidence enough that doing things differently and putting in resources through the government with accountability and sustainability is a successful way to go. In terms of measuring to the specifics with numbers, I know that the foundations are looking to do some evaluation that would also look at cost effectiveness, but I will let Yusuf speak to that part in more detail. Yusuf?
Thank you, Rehana, and thank you, Mohammed. So what we have done was to look at the cost per child immunized. And when we did that in the early phase, we realized that it's quite cost effective. But two other things happened. Like I said in my introductory remarks, that this partnership was an evolution. It was evolving over time. And what we essentially were doing was to build on it to address the emerging problems. So it was initially for polio, but while we were achieving the goals of polio, we realized that there were risks if we could not strengthen the routine immunization system. So we opened it to cover routine immunization. And in the later days, we also expanded it to PHC. So those incremental interventions that have been added have actually diluted that. But in the early days of the pure RI implementation, we did cost per child immunized, and it was really quite cost effective. But we can also share some of the initial analysis that were done.
Thanks, Yusuf. Liz, any further comments or questions?
I think most of them have been answered. I know Munir had commented a little earlier around I guess service providers are basically earning salaries, but the majority of service providers conducting routine immunization outreach are not really staff. They're casual workers, whom in most instances are not salary earners. And then we have a comment that just came in from Samuel. He said, ideally, if community engagement strategy is well done, defaulters should be the priority beneficiaries during outreaches, in addition to other remote population. In which case health workers would most likely immunize more. But the reality is that some health workers just go without using this as a guide. We need to start thinking more about strengthening this so we can get more value for money.
Yeah, so I was just saying that for health workers, regardless of whether or not they are volunteers, because the accounts are typically open for the health facilities and not necessarily individuals, it's very easy for non-permanent staff of all health facilities to still have access to funds. We understand that in many states, northern Nigerian states inclusive, we have a lot more volunteer health workers than permanent staff, but that doesn't pose a problem as funds are disbursed directly into the health facility accounts and not necessarily the individual's accounts. I hope that answers the question. Over.
Thanks, ID. I think that the other angle to that is now thinking through the motivation of health workers that are volunteer. And what we've tried to do over time is continuously advocate for recruitment of health workers and redistribution to more rural areas so that we can have some form of accountability or a higher form of accountability for volunteer health workers and a cadre of qualified professionals delivering immunization. But that is still a journey that is still in the early phases, getting states to recruit new staff in the midst of fiscal space constraints has been seen to be challenging. But we're always open to more ideas on how to solve this or how you might have circumvented these challenges in your respective programs. Liz, in the absence of any question, we'll hand over back to you. To everyone that joined, thanks for your time. And please feel free to reach out to us via email and also download some of the material that we have that document this work in more detail. Thanks. Over to you, Liz.
Great. Thanks so much, Rihanna. And thanks to the entire CyDR team. That was an excellent presentation, and really also appreciate the questions and comments coming in from our audience. So I just have one more slide to go over. So one just would join us on the Boost community platform. On the platform, you'll find a number of resources, as I mentioned, other bright spot stories, but we also have other live engagements and courses that we offer throughout the year. So I encourage you all to create a free member account online to access that platform. We also have a learning group on the platform dedicated to our bright spots. So if you have further questions from today's presentation, feel free to share them in that learning group, and we'll make sure they get answered. And then last but not least, we encourage you all to take our post-session survey, which my colleague MJ has just entered into the chat box. We really appreciate your feedback on this session, and it'll help us improve for future webinars. Next slide. And then one just last announcement, we are actually launching a new initiative called Boost Sparks, which is actually surfacing some of the bright spots that we shared out so far in real time. So we have actually an audio clip coming soon that will be published next week. So again, encourage you to register for a Boost member account, and you'll get all of that information there. With that, I want to go ahead and thank again our presenters for a wonderful presentation, and really appreciate everyone in the audience for joining us today. We hope to see you soon. Thanks, everyone.